and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Joyelle Ray Alexander, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we will be taking your questions throughout the hour by phone. The toll-free number is 800-452-0662, or you may send your written questions by fax. The fax number is 518-426-0696. We will also be taking questions by email. Please email us at any time throughout the hour at phlive.newyork@gmail.com. Additionally, the School of Public Health would like to remind you of the new companion guide for the Public Health Live program. The guide can be found on our website, phlive.org, and will provide guidance, discussion points, and learning activities for those looking to enhance their learning experience with our program. Please visit our website at phlive.org to download the guide for today's program. There is a section in the guide asking for audience feedback for how we can improve this product. We look forward to receiving your faxed or emailed comments or suggestions for this guide. Today's program is Dementia Update, a new national plan for Alzheimer's disease research, care, and services. Our guest is David P. Hoffman, the Bureau Director for the Office of Health Insurance Programs at the New York State Department of Health. Thank you so much for being here, Dave.
Thank you, Joyelle.
It's a pleasure having you here. Today's topic is such an important and far-reaching topic that I think we would be helpful if we started off by looking at a video produced by the Alzheimer's Association that will give us an introduction to the scope of the problem we are facing. What a powerful video, and certainly some alarming numbers. Dave, it looks like we've got a lot to talk about today, a lot of ground to cover. And for the information we can't cover today, it seems like the Alzheimer's Association is a great resource for further information as noted in the video.
Absolutely, Joyelle. The Alzheimer's Association is a terrific resource both for data and also for caregivers. And the best way to reach them is on their webpage at alz.org.
Terrific. And Dave, one of the things you'll be talking about today is some of the cost associated with treating Alzheimer's and the cost incurred by caregivers. Can you tell us about some of these costs?
Absolutely. The bottom line is that significant number that we saw in the short video there, $200 billion. But what makes up that number is also very important. In some senses, it's easier to measure the healthcare costs, the cost to insurers, to Medicaid, to Medicare, but the out-of-pocket expenses for caregivers and the cost to business is very significant. Cost to business both in terms of absenteeism and presenteeism, and the caregiver costs we have a hard time quantifying.
And I also understand that a person having Alzheimer's significantly increases the costs associated with both Medicaid and Medicare payments. Is that correct?
That's correct. If we look at the numbers on this slide, it's easy to see that a diagnosis of dementia, of Alzheimer's disease, the most common form of dementia, in and of itself is a predictor of significant increases in healthcare costs. This has a dramatic impact on people's health and their ability to manage their health.
Dave, explain to our audience why Alzheimer's is such a cost driver. I think we've really got to try to get a grasp of that.
Alzheimer's is a cost driver for many reasons, but primarily because it's an expensive condition to manage and treat itself, and it impacts both the caregivers and the person with the disease ability to manage all their other health conditions. When we think about the fact that 30% of people with Alzheimer's are on Medicare and Medicaid, we know that most people with Alzheimer's have one or more other serious chronic conditions, and dementia complicates their ability to manage those conditions. A senior with diabetes and Alzheimer's costs Medicare 81% more than one with diabetes without Alzheimer's. This results in more hospitalizations, fewer preventive services being provided, more complications, and importantly, more serious complications. Things like hypertension and other heart disease, diabetes, cancers, and arthritis are all harder to manage when someone has dementia, and it results in more and serious complications.
Clearly. And Dave, am I correct that this is a major concern because the number of people with the disease is actually growing?
Absolutely. The number is growing. Some of that has to do with our aging population, but also it's a change in the way our healthcare community is dealing with dementia. There's a growing awareness of the importance of early diagnosis and the benefit of early diagnosis.
So what does the current Alzheimer's landscape look like?
Well, there are some scary numbers here, Joelle. About 5.4 million people are living with this condition. Most of them, 5.2 million, are over the age of 65. But more than 200,000 are under the age of 65, and they have what's referred to as a younger onset version of the disease. Among people 65 and older, 1 in 8 has Alzheimer's. Nearly half of people over age 85 have Alzheimer's. Every 68 seconds, as we saw in that video, someone develops Alzheimer's, and by 2050, that number will be every 33 seconds.
Those are absolutely astounding numbers, and it's incredible to think that beyond those suffering from the disease, there's also such a huge impact on those that care for them. Can you talk to us about that?
Sure. Over 15 million people who provide care for people with Alzheimer's provide over 17 billion hours of unpaid care every year. If we wanted to quantify that in terms of dollars, it would be $210 billion. Additionally, being a caregiver for someone with dementia takes its toll on the caregiver as well in terms of their health and their mental health. The Alzheimer's Association estimates an additional $9 billion in healthcare costs associated with being a caregiver. This is for many reasons. The impact on physical and mental health happens. The risk for chronic conditions goes up. It happens because they lack time for physical activity. They lack time to assure that they have proper nutrition. They have less time and energy to avoid tobacco. Kind of the common risk factors that we think about for other chronic conditions. And all of these things, the time constraints, the stress, both physical and financial stress, and isolation really take their toll on caregivers.
So this disease is actually impacting and affecting a tremendous amount of people, isn't it?
Yes, it is. Yes, it is. When we think about this 15 million plus group of caregivers, as we saw, if these were the residents of the imaginary state of dementia, it would be the 5th largest state in the country. These people are wrestling day and night with the challenges that are both hard to understand and hard to address, often while handling their own health and other needs. These individuals are often an aging spouse with their own health challenges, dealing with the emotional loss associated with dementia, or adult children caring for a parent with dementia while parenting their own children. Sometimes we even see children and adolescents as caregivers for an older relative. Every situation is unique, but as you can see from these examples, nothing is easy.
Yeah, so it's evident that Alzheimer's is widespread and impacting many, many people. What can you tell us about the disease itself, Dave? Some people may still think that Alzheimer's is just a disease that affects memory, for example.
That's a pretty common assumption, and that's because memory is the first symptom that tends to appear. Alzheimer's is the most common form of dementia. It represents about 80% of dementia. It is not a normal part of aging. That's very important. It impacts mental ability and later in the process physical functioning enough to interfere with daily life. Memory, as I said, is usually the first core mental function where we notice a change, but that's followed by communication and language, ability to focus and pay attention, reasoning and judgment, and visual perception. At least 2 of these areas must be impacted for a diagnosis of dementia. Alzheimer's is also fatal for those who don't expire from some other condition first. As you see in the slide, it's the 6th leading cause of death, but we all understand that for many people with dementia, the cause of death may be listed as something else like pneumonia or stroke, but the underlying Alzheimer's disease or dementia was really the cause.
I see. And Dave, has there been any progress made in decreasing the incidence of Alzheimer's deaths? It seems that we've made progress with many other leading causes in death, and where are we with this?
We've had some great success addressing a number of conditions, but unfortunately this is an area where the numbers are going in the wrong direction. The only positive is that we're seeing the condition get a lot more attention, both nationally and internationally. In March, the World Health Organization issued a new report, Dementia, a Public Health Priority. And in the last 2 years, we've seen much more attention paid to dementia in Washington.
Now, you've clearly laid out the landscape for us. What I'm wondering is now, because of the nature of this disease, I would imagine that there are even greater implications for those who live alone. Is that true?
It is true. The Alzheimer's Association this year issued a special report as part of their annual publication of facts and figures, estimating that 800,000 people, 1 out of 7 people with Alzheimer's disease, live alone. And up to half of these people don't have an identified caregiver. I'm really glad that the Alzheimer's Association focused on this population this year. They brought to light a situation that's pretty scary. Think about what it takes for you to live your life every day and try to be healthy. Then imagine this huge number of people trying to live life lacking many of the tools that you and I have.
Dave, could you share with us more detail about the people who tend to live alone?
Yes, these people tend to be older, they tend to be female, and less cognitively impaired. But on a daily basis, they wrestle with things like managing their money, shopping, preparing meals, doing household chores, and importantly, managing medications. Remember, this is a population of people frequently who have other chronic conditions, and it's important for them to take their prescribed medications on schedule, but given the dementia reflected in a memory problem first, that's hard to do. These significant deficiencies in practical activities, things that most of us take for granted every day, result in a real risk to these people and the people around them.
Well, let's talk about that. Obviously these folks would be at a greater risk for some things. Can you talk to us about that?
Sure. They are at greater risk for malnutrition, untreated medical conditions, inadequate clothing or housing, falls. I want to stress falls because that's frequently a reason for hospitalization. That's an avoidable hospitalization. Wandering away from home unattended, accidental death, more frequent hospital stays and longer hospital stays, higher per person outpatient costs. But the list here doesn't tell the whole story. Often the items on this list serve to multiply the impact of other items on the list. A person who's malnourished can have a more severe impact from untreated medical conditions, and both of those can lead to falls or more hospital stays. You can see that everything here relates to the whole person and their risk. We need to think about the basics: promoting health, maintaining health, and safety. There aren't any easy answers to address this population of people living alone, but it's really good that the conversation has begun.
Absolutely, and I love the point that you've made. I want to just underscore this, focusing on the whole person, every aspect of that being. Dave, what kinds of advanced planning can be done to help prepare a person who lives alone?
First of all, early identification is essential, and advanced planning is critical. And it has to be comprehensive planning. It has to happen early in the stage of the disease so the person with the disease can fully participate while they have the capacity to do so in making decisions about their own living situation and their life. They can help build their care team. They can make legal and financial plans. Care consultations can be very helpful to people who live alone, and they can receive counseling on finances, long-term care planning, advanced directives to drive their health care, and receive assessments of potential safety threats. We know that planning can make a difference for these people, but it needs to be comprehensive. And it needs to recognize the progressive nature of dementia. So the more planning that can happen early, the better for the person with the disease, for any caregivers that they have, and for healthcare providers that work with them.
It seems so overwhelming. And just to be clear, once the initial diagnosis is made, that is the beginning of the advanced planning, so to speak.
It should be.
It should be.
Absolutely. That's correct. That should be the trigger for advanced planning, for legal issues, for financial issues, for healthcare issues, for housing issues, and putting together a care team that predictably will need to be in place to help this person live.
A care team, a comprehensive care team.
Right.
Now that we know a bit more about what individuals can do, let's take a look at the bigger picture, if you will, Dave. How does the funding for Alzheimer's research look? Where are we with that?
Well, we're not where we could be. When we look at these comparison numbers, for every $28,000 in Medicare and Medicaid spending, then the National Institutes of Health, the federal agency that oversees most federally funded research, spends $100 on Alzheimer's research. And this year, the CDC will spend only $2 million on public health efforts to address dementia. So nationally, we've got an issue of scale here. These numbers kind of speak for themselves. One of the difficulties that policymakers have had historically in understanding dementia is that unlike some other conditions, the people most in need are often not able to speak for themselves. Support groups like the Alzheimer's Association have started to make a change in this area, but there's need for more.
Absolutely. We've made inroads, and programs such as this program today takes a role, so to speak, in the advocacy movement. Would you agree with that?
Definitely, definitely. The more people who are aware, the better off we'll all be.
Absolutely, I agree with you. So clearly, we need more funding for Alzheimer's research, and this situation has even caught the attention of our president, who has made it a top priority. Can you talk to us about that today?
Absolutely. We were very excited a year ago when President Obama issued his vision statement on the National Alzheimer's Project Act, which passed Congress early last year, and he signed into law, indicating that it's an important challenge, but that as an important challenge, it's one that the federal government is ready to take a leadership role in. Importantly, because the president made this statement and signed this law, agencies across the federal government have become engaged, and that's an important consideration.
An important consideration indeed. Dave, give us some more information, if you will, on the National Alzheimer's Project Act. What are some of its purposes?
Well, some of the purposes are to create and maintain an integrated national plan, importantly an integrated plan, and I'll talk more about that in a minute, to coordinate research and services across all federal agencies, to accelerate the development of treatments to prevent, halt, or reverse the disease, and to improve early diagnosis and coordination of care and treatment. Importantly, this is a national plan and not a federal plan. It's not a plan for federal agencies to implement on their own. We all need to work together.
We all need to work together. And does the Act also focus or have as a purpose racial and minority groups as well?
Absolutely, Joelle. This is really important. The goals are to improve outcomes for ethnic and racial minority populations at higher risk. We know that African Americans are proportionally twice as likely to have dementia. Hispanics are 1.5 times as likely to have dementia. We don't know exactly why, so these are important questions for us to ask. Additionally, the plan calls for us to coordinate internationally to fight Alzheimer's. This is not an American problem, it's a human problem. And we would be burying our head in the sand if we didn't realize that other countries are wrestling with this issue and spending resources on research and things there too, so we need to work together. Also, the Act called for the creation of an advisory council to review and comment on the national plan and its implementation.
Dave, who's guiding the work that's being done by the project?
Dr. Ronald Peterson is chairing the council that I just mentioned. He's from the Mayo Clinic. He's a well-respected leader in this field. There are 11 council members who are outside of federal agencies, and every key federal agency with a role here has a seat at the table. Both the Department of Health and Human Services, which is in the lead, the Department of Defense, the National Science Foundation, and the Department of Veterans Affairs. The Veterans Health System is one of the primary providers of care to people with dementia.
This is good news. It looks like an all-hands-on-deck approach.
It really is.
Now, I understand there was a proposal to invest $156 million on Alzheimer's research. What can you tell us about that?
Well, let me review the proposal just as an overview. This investment was designed to take immediate action without waiting for Congress and support for the national plan, to increase funding at the NIH, the National Institutes of Health, immediately by $50 million during this year. This is already underway. And then to sustain and grow Alzheimer's research investment in the federal fiscal year 2013 budget by $80 million beginning on October 1st. It's important to note that Congress hasn't acted on that proposal yet. It's also important that we understand the need for many types of research, for new medicines, but also for ways to identify the disease early, any kind of preventive strategies that we can come up with, and very importantly, research on supporting caregivers and how to do that best.
Well, what I'm wondering also, does it also take into consideration supporting families and providers and educating the communities at large?
There are some resources that are dedicated to that. If we look at the proposal, there's $26 million this year and next proposed in the federal budget. For education and outreach, $8.2 million. Outreach to enhance healthcare providers' knowledge, $6 million. It's really important that healthcare providers understand Alzheimer's disease and dementia and how to work with people. Support for people with Alzheimer's disease and caregivers, $10.5 million. And improved data collection and analysis, $1.3 million. My observation here would be, as I mentioned a few minutes ago, we're really talking about the wrong scale. I read last night that one super PAC spent $8.2 million in one weekend in one state. So on election advertising, $8.2 million can be spent in a weekend, but that's the annual budget to educate Americans about this important condition. I just make that comparison because I think it puts it into perspective.
Duly noted. Tell us about the subcommittees and their roles.
These three groups each address one of the core areas that we need to improve to reach the overall goals of the national plan. Growing research seems to be just common sense, but improving clinical care and support services for people with dementia and their caregivers now and in the distant future is also really important. I've had the honor to chair the group focused on long-term services and supports, and I'm here to tell you that the caregiver members of this group have added tremendous perspective and knowledge to the discussion.
Absolutely. If not at the head of the table, they've really got to be right there, and I'm certain their presence is valued. And tell us how the draft plan was developed. Can you share that with us, Dave?
Sure. As with many government processes, getting members appointed to the council took some time, but the federal government got a jump start on this. They formed an interagency work group to the advisory council, and they started with an inventory of what the federal government had been doing related to dementia across all agencies. Formal meetings of the advisory council and work groups and subcommittees have been happening over the past year. Work to date addresses the current programs serving people with Alzheimer's and their caregivers, improvements to those programs that might be possible, and some suggested new initiatives.
Now, is this a federal plan?
Importantly, it's not just a federal plan. It is a federal plan, but it's really a national plan with goals for the federal government, but goals for state governments and the private sector as well. Dementia is not something we can address exclusively with federal government activity. We need to harness the resources of outside groups, and we all need to work together. This national plan includes activities that are immediate actions, near-term actions, and longer-range goals. It requires the engagement of both public and private stakeholders. The path forward will be contingent on resources, contingent on scientific process, and importantly, contingent on collaboration. The research summit that was held by NIH in May to focus on Alzheimer's disease called on researchers to work together and collaborate in ways that they haven't in the past, to share knowledge and progress to accelerate the process.
What are the principles behind the national plan?
The principles are very basic: to optimize existing resources, to improve and coordinate ongoing activities. We can't afford to misuse limited dollars. To support public-private partnerships in consultation with the Advisory Council, acknowledging that we all need to work together. And to transform the way we approach Alzheimer's disease. We really need a new paradigm, a new reality in the way we look at Alzheimer's disease. We've talked in the past about Alzheimer's disease, about a tidal wave that was approaching us. It's here.
Absolutely. There's no question about that. What about the specific goals of the plan, Dave?
The specific goals of the plan are ambitious. To prevent and effectively treat Alzheimer's disease by 2025, to optimize care quality and efficiency, to expand supports for people with the disease and their families, to enhance public awareness and engagement, and to track progress and drive improvement. As I said, these are ambitious goals. Secretary Sebelius and the White House have compared this to President Kennedy's goal to put a person on the moon, or the collective war on cancer that has seen so much progress. It's important to note that while these are ambitious, they're also reachable goals. We need to push ourselves and one another to achieve them.
Ambitious goals are good, particularly in this instance, and we've made some very significant inroads, but we can't stop now. As you say, we've got to push on to yield results from all of our good work.
You said it. Definitely.
Now, each goal has several strategies in place to help ensure that this is accomplished. Can you tell us about the first goal and its strategies?
Yes. Preventing and effectively treating Alzheimer's disease by 2025 is going to take significant action. Identifying research priorities and milestones, which has already started. Expanding research aimed at preventing and treating the disease. Accelerating efforts to identify early and pre-symptomatic stages of the disease. Coordinating research with international, public, and private entities. And facilitating translation of findings into medical practice and public health programs. We can't afford to do good research and let it sit on a shelf. This problem is here today. We need to conduct research and translate it as quickly as possible.
Absolutely. And what about the second goal? What does that lay out for us?
Our second goal acknowledges that in order to address this issue, we need a capable workforce. One that understands the complexities of dementia, that works for early detection, that helps support people with dementia and their caregivers, begins that planning process on early diagnosis that we talked about, and follows guidelines for what works. This is going to take a significant amount of pre-service training for professionals and paraprofessionals as they prepare to begin careers, and also in-service training for people who are in the field today so they understand the guidelines of best practices that are available.
So schools of medicine, social work, schools of social work,
nursing,
certainly
absolutely.
Schools of public health
Definitely.
are beginning to take this on as a priority and begin shaping the goal.
We hope so.
Have you explored the effectiveness of new models, Dave?
This is a process that's just beginning, and it's going to take some time. The second goal under enhancing care and quality leads us to a key here, safe and effective transitions. This is an area we know can be improved. A Harvard University study that was published this week confirmed that transitions to the hospital itself can cause complications and be a driver for admission to nursing homes. So we need to do what we can to keep people out of hospitals by providing better care where they reside. Coordinating care and support systems is an area where we need to make improvements and recognize that the presence of supports has a direct impact both on the person with the disease and their caregiver. There are some groups that are impacted by dementia more than others, and we need to have a better understanding of these disparities, and we need to address them.
What about the third goal?
Expanding supports to people with this condition and their families is going to take a full court press. We need to ensure receipt of culturally sensitive education, training, and support materials. We need to enable family caregivers to continue to provide care, assist families where we can, Importantly, maintain dignity, safety, and rights for the people with this condition, and assess and address their housing needs. We know that these supports can make a difference. Dr. Mary Middleman at NYU has been studying this issue now for some 20 years, and she has shown with her long-term studies that with appropriate supports, people with dementia can live in the community with dignity, safely, and with caregivers feeling supported for up to a year and a half longer than otherwise expected. That's significant knowledge for us to share.
And I once heard someone say, and when we know better, we do better.
Exactly.
And the fourth goal, can you take us through that?
Public awareness and engagement is going to be the key for our progress here. There are lots of myths and fears about dementia that need to be addressed. People need good information. As you can see from the earlier slides, this is a daunting issue, and we don't have a lot of resources to make this happen, so we need to work together on this as well. But it's really important that we understand the facts about dementia.
And finally, tell us about the fifth goal, Dave.
The fifth goal is the accountability goal. This plan has built into it a monitoring of progress so that the public and constituent groups like the Alzheimer's Association, state governments, healthcare providers, and others can hold one another accountable for progress on these goals. Importantly, the plan also links to other federal plans. It acknowledges right up front that dementia is not happening in a vacuum, and one of the key federal plans that it links to is the Framework to Address Multiple Chronic Conditions. The population of people with dementia, by and large, is also the population of people with multiple chronic conditions. So that linkage is really important.
Very important, and it's exciting to see, the collaboration that is such an intricate part of the goals. What are the recommendations of the National Council?
The National Council, representing those non-federal members of the Council, also published a set of recommendations. Those recommendations tend to be more specific and more robust than the recommendations that were in the federal plan. They really kind of set the stage for the next version of the federal plan, but they include things like increasing initiatives spanning basic translational and clinical research to address disparities. The Council recommendations go far beyond some of the recommendations in the national plan. And this is a process that's ongoing. So these recommendations are really going to help us move the plan forward as the months progress.
Now, let me ask you this, Dave. Will the aspects of the National Council's recommendations, will they kick in, so to speak, once the goals are fully resolved or fully engaged, and then they kick in, or will there be this kind of transition that takes place?
That's really a good question. It's more of an evolutionary process. The recommendations of the council members are going to enhance the national plan in the annual iterations of the plan as it's published. And that's an ongoing process. Council members are now talking about the 2013 plan, so that's already occurring.
Good. So it sounds like there will be a seamless transition, if you will.
We hope so.
Okay.
Yes.
And were there recommendations regarding the funding?
Yes. The council recommendations call for expanded funding and incentives for healthcare providers, for funding associated with state education and health agencies and others to include key information about Alzheimer's disease in all curricula for any profession or career track that affects long-term services and supports. Also, redesigning Medicare coverage and physicians and other healthcare providers' reimbursement to encourage an appropriate diagnosis for Alzheimer's disease. That's not incentivized in a way that's effective today, and to provide care planning to diagnosed individuals and their caregivers. It's important that advanced care planning that we talked about earlier is something that's reimbursed in the process. and not something that's just an added task for providers working with people with this condition.
Does the funding extend to all of the states?
At this point, there's not enough funding for all states to engage in these activities. That's really a role for the public and the advocacy community to educate policymakers about that need.
Very well. What are the other aspects of the recommendations?
Importantly, the recommendations call for a robust, dementia-capable system of long-term services and supports, and that be available in every state. States should ensure that paraprofessional caregivers are adequately trained and compensated. The process of diagnosis should include engaging the individual and family members in advanced care planning, as we mentioned. Health and Human Services should assure that health and related systems funded with federal resources should improve chronic disease treatment and related services for people with Alzheimer's disease, and develop quality measures and indicators for the comprehensive care and treatment that we've been talking about.
Dave, the plan for 2013 is underway, is that correct?
That is correct. The council meeting is scheduled for July, and some of the subcommittee groups are already in discussion, so it's an ongoing process.
Good. Dave, share with us the contributions made by New York State.
New York State has a coordinating council on Alzheimer's disease services, and the committees of this group have deliberated over the past couple of years, and a few months ago issued a report. This was the second report from this council. There were significant contributions from the field, both caregivers and providers and others. And this report includes some groundbreaking recommendations. Dr. Shah, our New York State Health Commissioner, was very interested in having this report include meaningful recommendations.
And what are New York State's recommendations?
New York State recommends cognitive screening for everyone age 65 and older as part of their normal health care. So at their annual physical, if they need to make an emergency room visit or an urgent care visit, that cognitive screening should be part of that care. To include key information about dementia in all training. We heard that in the national plan, and it's echoed in the state report. To engage our Alzheimer's disease assistance centers, 9 centers that are located around the state, and other partners to develop this training. To explore possibilities and partnerships for public awareness. And that providers should engage people with dementia and their family in advanced planning at the earliest opportunity. Once again, echoing the national plan, New York's report was actually out first.
Wonderful. You know, and with New York State being so diverse and so large, the 9 centers you speak of, are they as far out as, up in the North Country and way out west, and also in some of our urban markets? Are the urban, suburban, and rural markets being impacted at all by the 9 centers?
Absolutely. They're geographically dispersed from Long Island to Buffalo to Plattsburgh to New York City. But at the same time, we don't pretend that we have enough Alzheimer's disease assistance centers or that they have enough resources to do everything that needs to be done today.
Well, this has been incredibly helpful information. I understand you have further resources to share with our viewers as well that they can access on the internet?
Yes, there's a slide with information for web links to the New York State Department of Health web page. There's a dementia page that has a number of links on it that people can use, as well as information about dementia that they'll find useful. There's a new federal site called alzheimers.gov that was just initiated last month with the issuance of the national plan. The National Alzheimer's Project Act site is listed there, so if people want to follow the activities of the National Council, all the council meeting materials and background materials reside on that website and are in the public domain. And as I mentioned in the beginning, Joelle, the Alzheimer's Association site is a terrific resource for people, and that's listed there as well.
Dave, before we open this up for questions, I'd like to give you an opportunity, if you'd like, to give us your kind of takeaway points that you think are most valuable for our audience today.
Thank you. I think it's important for all of us to understand that the time to talk about dementia is now, that the problem is here, and that the good news is policymakers are becoming aware of these issues. We're seeing things like the World Health Organization report in March, and now a national plan, and this report from the New York State Advisory Council acknowledging the issue, making some concrete recommendations, and as you've heard me say several times this morning, we all just need to work together.
I agree. Thank you so much, Dave. We're going to open it up for questions. We already have some questions that have come in for you. The first question, you mentioned myths about Alzheimer's. Can you give us a couple of examples?
Sure. There is a myth associated with Alzheimer's that it's caused by aluminum. Scientific studies have shown conclusively no relationship between aluminum and Alzheimer's. That's an important consideration because aluminum is found in many deodorants. So many people use a product with aluminum every day. I would encourage people to go to alz.org, and there is actually a page on the Alzheimer's Association site that debunks myths. There's a whole list of myths there, and they give scientific citations that people can follow and read themselves.
Thank you for that. Here's the next question. Can medication slow the onset of Alzheimer's disease?
Currently, there aren't any medications that slow the onset of the disease. There are medications on the market that can assist people with some of the symptoms associated with Alzheimer's disease. I'm not a physician, so I'm not going to give people advice about medications, but I would encourage anyone who suspects a diagnosis of dementia or Alzheimer's disease to talk to their healthcare provider and listen to their advice very carefully.
Thank you. Here's a question that we hear quite frequently. Is Alzheimer's disease genetic?
That's a really good question. There was actually a long article in the New York Times a couple of weeks ago about a family in Oklahoma where a significant number of family members developed an early onset version of Alzheimer's disease. And we know that dementia is a set of diseases. It's not a single condition. And that some of those diseases and some forms of Alzheimer's disease have a genetic component. The research is ongoing. We don't know what that genetic component exactly is, but it's important that that research continue because we can learn from that.
And the funding will assist with the research.
Absolutely.
Here's a follow-up question that corresponds nicely with that. It's just been emailed to us from Cincinnati. How much of Alzheimer's funding or proposed funding is also or is associated with the Affordable Health Care Act?
Actually, some of the numbers that I mentioned, the $26 million that goes for things like workforce education and public education, in the president's proposed budget was all proposed to come from the Prevention Public Health Fund, a groundbreaking fund that was part of the Affordable Care Act, acknowledging right up front that our healthcare system today doesn't do enough in prevention and that prevention is really going to be a key moving forward. As I mentioned before, Congress hasn't acted on those proposals yet, so we don't know what that will be moving forward after October 1st.
Thank you. Here's a question that's come in from the New York Academy of Medicine. Any advancements that have been made regarding Alzheimer's disease that you're aware of that you can share with us today?
Yes, I actually have been pleasantly surprised to see when I went back and tracked in the lay press, on the internet, in major newspapers like the New York Times and others, there have been published stories about Alzheimer's research every week this year. That's a significant improvement over what we saw in the past. What it tells us is that dementia is in the news. It tends to be in the news when a new research study, like that Harvard study about hospital transitions that I mentioned, was published this week. I think it's important for people to read past the headlines when they see those stories. That's one way that the public and providers can be educated.
That's an excellent point. And social media could also play a tremendous role in passing on those headlines and the valuable information that's out there. We touched upon some of this information earlier regarding diagnosis. How is Alzheimer's disease diagnosed?
As I said, I'm not a physician, so I'm not an expert in diagnosis. It's not an easy diagnosis to make, but when we look at that list of conditions that I mentioned, when 2 or more of those conditions are present, a healthcare provider can make a diagnosis of Alzheimer's disease. And it's important for healthcare providers to consider that diagnosis. The old conventional wisdom was, don't tell the person they have dementia because there's not much we can do about it. The new conventional wisdom is, particularly after reading Mary Middleman's research, there's so much we can do in terms of helping the person with the condition and their caregivers prepare a plan, develop their care team, get ready for the future, that earlier information is better information.
The earlier, the better. Here's an email question that's coming from Florida. Any information by new diagnostic test using PET scan?
This is not an area of my expertise. I'm aware that there's research going on with PET scans and diagnosis. I'm not sure what that is. I would encourage the questioner to go to the National Institutes of Health webpage where they can read about what research is currently happening.
Fair enough. Thank you. You've done a tremendous job today underscoring, highlighting, emphasizing the tremendous burden oftentimes taken on by caregivers. Here's this question. What advice do you give to caregivers?
My advice to caregivers is to take advantage of any resources in their community that are available to help them. Reach out to friends and family. Reach out to community groups like the Alzheimer's Association that have support group activities, that have caregiver hotlines where you can call an 800 number at 2 o'clock in the morning when mom or pop is wandering around the house and you don't know what to do next, and a trained individual can help you work through that situation and find a satisfactory conclusion. Once again, the website to find resources through the Alzheimer's Association is alz.org, or folks can find those resources through the New York State Department of Health webpage, nyhealth.gov.
Thank you. Here's a question that's come in via the phone. How do they determine the difference between Alzheimer's disease and other dementia?
The differences are designated primarily through a variety of tests that are done. And the tests are very important because there are some forms of dementia, some forms of condition where the symptoms present as dementia, where they're reversible. So sometimes the dementia can be the result of polypharmacy. Someone's taking too many medications, or they're taking them at the wrong time of day, or they're taking the wrong medications with one another, and the symptoms can present as dementia. It's important that tests be done to avoid that situation and correct the problem when it can be corrected. Some types of dementia can be diagnosed better on using imaging, and as I said, I'm not a physician, so I'm not an expert in this, but the testing that is done as a part of the diagnostic process typically rules out some of those reversible conditions in order to reach a diagnosis.
Thank you. Here's a great question that's come in via the phone. Can you address memory cafes? And is there research that these memory cafes work to help dementia patients and their caregivers?
I can't address that. I'm not familiar with memory
Neither am I,
cafes. That's a new
yes.
one to me. What I can say is that there are a variety of activities happening that we read about all the time. Use of the arts, use of museums, use of music, choirs, etc. For people with various forms of dementia that have been shown to have a calming effect and to enhance their life, to give people a better quality of life.
Thank you. I believe this is the last question that we have today for you. When will the next national plan be released?
The next national plan is scheduled to be released in May of 2013. The first national plan came out in May of 2012, and we're looking for that to be an annual process, and council members will push the federal government to meet that deadline.
Dave, you have come here today armed with a tremendous amount of information. I want to thank you on behalf of Public Health Live for the great work that you're doing in New York State through the Office of Health Insurance programs and helping caregivers and those with Alzheimer's and dementia.
Thank you, Joyelle. My pleasure.
Thank you. And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help further your knowledge and understanding of topics covered in today's very important program. An archive of this webcast will be on our website within 2 weeks. Please join us on July 19th for the next Public Health Live broadcast on using social media in public health. I'm Joyelle Ray Alexander. Thanks so much for joining us on Public Health Live. Thank you.
Thanks, Joyelle.
Thank you.